Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the Low Carb MD podcast. I'm going to gloat already because this is a topic that we touched on back in episode 10 and 13, and people thought we were nuts. And now there's tons of research about something that doesn't exist, apparently.
Well, I'm excited about the two guests we have today because not only are they clinically helping people through their clinic and at Sweet Sobriety, they're also fellow podcasters like us. So if you have not listened to the Food Junkies podcast, please go listen. But we have two special guests here, researchers and clinicians, which is my kind of people. We have Clarissa Kennedy and Molly Painschab. Did I get it right? She gives.
It looks good. It sounds good. Yep.
Just a little background about them. Clarissa Kennedy, she is a clinical social worker, and she was recently part of a very major study that was published in Frontiers that tackled food addiction. And she was part of, actually both Molly and Clarissa, were part of that paper, along with Jen Unwin and some others, which highlighted the role of low carbohydrate nutrition in food addiction and processed food addiction. So I'm just excited to talk about that paper. And they've been working together for over, about, what is it, 5 years, guys? You guys have been working together?
Yeah, I think it's about 4 or 5 years.
Right, to tackle food addiction here in North America. Molly is a mental health counselor and addiction counselor, and she was also one of the co-authors on that paper. Guys, I'm excited to have you here. We got 4 podcasters in one Zoom room here. So what's going to happen here is me and Brian are going to do the shutting up, and we're going to hear you guys talk to us about one, maybe, how you came into this idea of food addiction, the field of food addiction, how you guys found each other, how you guys have worked with each other. And then, if we can hear how this paper came about, the backstory behind that, because, food addiction is not yet well recognized, and so how we'd love to hear the backstory first, and then the cool stuff later on.
Yeah, sure. This is Clarissa, and I can start. So my story is a personal and then professional journey. So I struggled with eating disorders and substance use in, basically from 19, and that was from like anorexia, bulimia, all of the eating disorders. And then it really trickled into substance use disorder with alcohol. And, I was able to somewhat resolve the eating disorders in that I was now maintaining a weight that I felt comfortable in, but I was still over exercising. I was still restricting. And I still didn't understand why I couldn't really feel recovery from it. And the substance use end on it really allowed me to only time that I could get some quiet from the noise of the eating disorder. And so, I eventually, when it got into recovery, but I still had some binge drinking episodes, and I'd already gone to school for addictions and mental health. I was doing all the things they were telling me I'm supposed to do for addiction recovery. And so I finally ended up at a treatment center. And at that treatment center, I was kind of sharing my story. And the medical director was kind of like typing in. And then she turned around and she goes, "Have you ever heard of food addiction?" And it was Dr. Vera Tarman. And so I think that was 2015. And then from there, she told me all about it. So I started going to school for it. I changed the way I ate, and it resolved my substance use disorder. And so I then became passionate because then I wanted to reach out to the treatment centers and places I'd gone for eating disorders to say, hey, I figured it out. There's like this subset of people who, it may appear eating disorder symptoms, but food addiction could be the thing. So every time you're telling them to practice exposure therapy in moderation, you're actually causing harm. And nobody wanted to talk to me. So that's how I just started my own, I already was a clinical social worker. So I just started practicing food addiction, and then decided in 2020 to ask Vera if she wanted to start a podcast, because I knew the word wasn't getting out enough. And I had just previously met Molly, but I'll let her dive in there because that's where she can let you know her story.
So, I find it very interesting because, the work on food addiction dates back at least about 20 years, if you really dig into the literature. And yet it's been so ignored. And I think, there's some giants in the field who have even recently sort of showed that it's so pervasive, that maybe upwards of 40% of obesity could be food addiction or sort of adjacent to food addiction. And here you are sort of reaching out for help, experiencing it yourself as a clinical social worker, and people are like, no, not even giving you the time of day. I mean, it's exactly
and I was seeing it in the clients I was working with, because they would go off substances and they would switch to food, and we're telling them, oh, that's a better choice. That's okay. But it's still keeping them unwell. And their mental health is really struggling because of it.
And I find that we face the same criticism. We still face the same criticism. And that's why I'm so honored to have both of you guys here, because you took the extra step of not only helping people clinically, but also putting it into the literature. And we'll get to that in a bit. So Molly, can you tell people a little bit about you and sort of how you came to this field, and then how you guys came together?
Yeah. So, similar to Clarissa, I have a background in working in corrections, Child Protective Services, Department of Corrections, all of that kind of stuff. And so the vast majority of my clientele were individuals who were attempting to get off of other substances of abuse, get out from underneath gambling, sex addiction, porn addiction, whatever it might have been, all the while doing my own work since I was about 22 years old, in therapy, talk therapy every week for years, trying to get to the bottom of whatever it was that was going on for me. And I was diagnosed with polycystic ovarian syndrome in 2010, and put on a lot of weight, 100 extra pounds, and really struggled to conceive all of the things, was able to finally have 2 children. And then I couldn't get the weight off. Polycystic ovarian syndrome is a beast like that, where it's very easy to put it on and very difficult to put it off. And my husband was listening to the Joe Rogan podcast, and Dr. Sean Baker was on, and they were discussing some of these things, as they do over 3-4 hour, these marathon sessions that people tend to have on his podcast. And he encouraged me to listen to it. I did some research, and I decided in November 2017, this is it. For 21 days, I'm going to do this keto thing. Whatever it is, I can do for 21 days. And if it doesn't work out for me, Thanksgiving is like day 22. So it's fine. But day 22 rolled around, and I didn't want to stop what I was doing. And I ended up following some people on social media, and this gal was reading Vera's book, Food Junkies, and said, hey, if you've never read this book and you're following me, maybe you should read it. And the addiction counselor in me starts reading it, and I am like frustrated and overjoyed. Like, I'm having all of the feelings, because I'm like, this was never taught to me in any of my master's degree programs, any of my continuing education units that I need to have, right? Like, this has never been a thing in all of my years. And this is potentially my truth. I just put it together kind of after the fact. So I immediately started researching how I could get specialized training, because I knew I wanted to move out of the world of methamphetamines and heroin and bath salts and all of the things. And this is what I wanted to do. So that's where I met Clarissa, was while I was at my training. Clarissa was helping to facilitate that in Northern Ontario. And so we clicked, and we just started working together. We would bounce out, case consultations off of each other, support each other in how can we get the message out, all of that. And then Clarissa did have the bright idea about the podcast with Vera, and we got her on board. And we started doing interviews in the fall of 2020. And then in January 2021, not only did we launch Food Junkies podcast, but we also joined up with Jen and Heidi in the UK and Charlotte and Frida out of Sweden for the research program that we did, which was really interesting. I had reached out to Jen because Clarissa and I had put together what I would call an intensive outpatient program based on our experience of running programs similar in the past. And Jen was like, we want to do this thing. Do you guys want to join us? It sounds like you're doing the work anyway, essentially. So that's how we got involved with the paper.
So walk me through. So, I'm just, I know in Canada, we've had Evelyn Boudoir-Roy, we've had some other Canadian doctors come on, and there's very sort of stringent laws and regulations around treating people with nutrition, or at least talking about nutrition. So, and the last time I checked, I think Joe Rogan was illegal in Canada. So can you guys help me?
Well, good thing I'm in Montana. So
yeah, okay. So can you guys help me understand? So what if have you faced any resistance to you practicing the way that you are?
I certainly haven't. In Ontario as a clinical social worker. I can see individuals as, social work clients. And yet I was seeing them under the guise of like food addiction counseling, because that's what they're struggling with. I'm also addiction certified, and this is an addiction for them. And that means there needs to be some level of a prescriptive food plan. And the more training I did, the more I also realized that this food plan needs to be self-determined by them with some loving limits and guidance from us. There is certain people that can't do keto very well. They might have a saturated fat intolerance, and they might find that too restrictive. And if it was too restrictive, then they might find that they would still be having binge episodes. So we would kind of find their right fit and then really work on meeting maybe once a week I also do a bit of texting and, support in between, because as much as I'd worked with alcohol, drugs, all of that, that's not something that a social worker supports you with in between sessions. But I knew this needed a different level of support. They needed to be able to text me pictures of food. What do you think about this? And I would say, show me the ingredients. And we'd talk a little bit about it. They would say like, I'm wondering about this food. And I'd be like, okay, is this something that you can eat in moderation? Is this something that creates mental obsession in your mind? Is it something that's ultra processed, hyper palatable? And, you feel like once you start, you can't stop. If those are the things, let's just remove them for now. And not saying like both Molly and I are harm reduction clinicians. And so there's a lot of, resistance, I think, in our field. They just want to go straight abstinence. And I really think that we want a more preventative approach, a more proactive approach. We want as many people to come in. And we also know food addiction sits on a spectrum. So there's going to be people who are mild, moderate, or severe. And somebody who's moderate needs a different treatment plan than somebody who's severe. So I would say, interestingly enough, the most resistance we've received has been from our colleagues in the food addiction field who want a very restrictive food plan. Even some of the 12-step programs are like, for every single person, it needs to be 4 ounces of protein and, 10 ounces of this. And I just feel
That's
that
an eating disorder. I'm sorry, I'm going to stop you.
Yeah.
That is an eating disorder.
Exactly.
I've had clients come from a 12-step program and have not had a period in months, and we get them on something less restrictive, and all of a sudden they're having regular cycles. And I think, the other way that we get around the food issue, the prescriptive food issue, not being dietitians or nutritionists ourselves, right, is that we really come at it. Our lane with the food is as mental health and addiction professionals. So we get to come at it and say, like, when you consume this thing, what is the reaction in your body? Is there a chemical dependency like reaction? Is it causing you to crave or binge? Is it causing you to have anxiety? bouts of depression, mood swings, right? So we really get to explore it in a different way. And then because it is self-determined and we ask these questions, right? We have these loving limits of like, first, let's remove anything that is acting like a drug in your brain. Then let's remove anything medically necessary. If you're allergic to peanuts, please, for the love of God, do not have peanuts in your food plan. And then finally, it's preference. And I always use raisins as an example for me. Raisins do not light up my brain in any way, shape, or form. They just don't. I'm not allergic to grapes, but I've had a raisin every way you can have it in my 40 years of life. And I haven't found one that I like, so I'm not going to have raisins in my food plan. And so with these kind of loving limits, people have really, it's amazing how they've kind of found this middle way without being overly restrictive and causing eating disorder.
Yeah, I think that it's a challenge, and I think that it's a lifelong learning, right? And also things change. Brian, you've talked about this. Sometimes I'll have patients come to me and maybe they're even sort of vegetarian or plant-based, and then all of a sudden, 6 months later, they're sending me pictures of steak and bacon, and so even the taste profile change, and just me personally over 8 years or so of eating in a consistent pattern, I've noticed that my own sort of preferences have changed. Cheese was not an issue for me early on, and nuts were not a huge issue for me early on, but these two food groups for me now are a challenge. And so I think the fluidity of this, the lifelong nature of it, right, and the need to reevaluate, so I love the approach of sort of that individualized approach. So you guys have gotten heat for being sort of middle ground. I want to hear more about this.
For being harm reduction clinicians, which is kind of the gold standard when you think about addiction treatment, right? So harm reduction often gets lumped together or used interchangeably with moderation, and it's bunk. They're two very different things, right? So harm reduction is a term that actually refers to us addressing the harms related to the use, right? So in the case of food addiction, it's going to be things like the binging and purging. We have clients to us that the first thing we have to do is get them out of that cycle. And we have colleagues that would argue, well, get those foods out and they would stop. And it's like, well, easier said than done, right? Like we kind of come at it at a more nuanced, approach. So that's just one of the ways that moderation and harm reduction are not the same. But again, because of that lumping together, they think that we're trying to teach people how to just eat less cookies. And that's not at all what we do. We actually just meet our clients where they're at. We allow them to design what their goals are, and we support them in that. Now, if those things don't jive, if they're saying one thing and the actions are looking like something else, it is our job to help them see that and try to come up with a new plan or a new goal, whatever it might be. And the ultimate harm reduction would be zero harm, which would be abstinence. Not everybody can get there. And I think you guys have probably seen that with the people you work with, whether it be in the food world, losing weight world, addiction in general world. It's not everybody can get there. And to have that expectation, I think, is cruel. And then we get heat for that because we don't have that expectation of people. I mean, would you agree, Clarissa?
Yeah, we certainly offered up to some of the courses that we took to say we'd love to present harm reduction. And we had a flat out, no, we're not talking about that. And then kind of very cold shoulder and no longer communicate or see eye to eye on things. And that's okay, because we know what we're doing is helping people, and we're not going to be everyone's jam.
Well, hold on. Not only do you know you're helping people, you have published your results. So this is a key factor. My colleague, Dr. Laura Buchanan, she published a poster on food addiction symptoms with just nutrition only, a nutrition only CGM patient empowerment approach. She showed that her method improved results. You guys have showed that it's improved results. So I think when it comes to treating people, and I'm going to say this 100% honestly, there's a lot of people out there, and there are very few people doing what you've done. So in my standpoint, I'm like, you teach me, because your results are documented. So what are you doing should be the question these people should be asking.
Right. And we didn't give, again, a prescriptive food plan in our 10-week study. We really said eliminate the ultra processed foods. And we also didn't really talk about the food except for in week 1 of the 10 weeks. And we know people's BMI went down, their well being went up, and their food addiction symptoms went down. And it's great to see in a 10-week intervention to have those kind of results is super powerful.
Yeah, absolutely. This concept of abstinence, Brian, you want to like chime in here? Because we've talked about this a lot. Abstinence.
Yeah, I've been wanting to say that. This is one of my favorite patients. On our first day we're meeting and her friend comes in, she's gung-ho, totally all in. And this lady's like, look, is it a deal breaker if I have sourdough bread sometimes or a glass of wine and I go, why are you cheating on me on the first date? Like, let's talk about it. Or like, why do you feel that way? Like, what, you're planning your cheat on me already? And she said, I've done Whole30. I've done all these things. I can go 30 days and be perfect on anything, but on day 31, I'm eating cookies and donuts and go back to the same old stuff. And so she's killed it because she goes, look, it's not worth it. I look at it and go, is it worth it? No, it's going to hurt my goal. And so once you take that fantasy out of Twinkies and they say, I had Twinkies, it wasn't even that good. What did you learn from that experience? So there's going to be these times when you have those kind of foods and go, I felt terrible for 2 days, not worth it. I eat pasta and my stomach hurts and I got gas for 2 days, not worth it. So when you start to say, okay, there's pleasure and there's pain. Okay, the pain outweighs the pleasure. Okay, we're not doing that. So when they can make that, or when they see their CGM and they say, oh my gosh, when I eat that, my sugar goes to 250. I don't like to see that. And I know what it's doing. They're educated. But a lot of it's not education. It's actually, what do I do when I'm in the battle and my husband's being a jerk? And I just got off the phone with a lady. She goes, I had like M&Ms twice this week. Like, I just like was frustrated and I had M&Ms, and she realized it's not a good thing. But at the moment, you don't care,
Yeah,
Absolutely
and I think
not, because food's the solution, right? Food is the solution there. Go ahead, Clarissa.
No, I was going to say, I think that there is, with food addiction, there's much more room for experimentation. And we don't, we dislike the word relapse. We'll often use slip and like, what did you learn? And how did you grow? And how did that make you feel? And ask those same questions. If I have somebody who comes to me on the first day and they say, I'm going to start working with you, but I'm going to eat that wedding cake in 6 months. I'm like, that's great. We can talk about that then. But for that moment, it's also just giving them hope, because I don't think I've ever met with anyone who hasn't said, this isn't going to work for me. I'm exhausted. I've tried everything else. And I'm like, just give me a few weeks. Let's just stay in this together. And you're right. Like, I worked with alcohol and drugs for so many years, and, I've seen people's lives change, but I've never seen people's lives change like when they change their food. They get their life back. And this is why we're working food from this addiction model, because we're teaching them abstinence and about withdrawal. We're teaching them the craving management skills, coping skills, talking about, because for the most part, it's not about the food, it's about this life they're trying to escape. And so we've got to help treat the life so they're not treating their life with food.
Or drugs or alcohol or computer games or
Whatever it might be. Yep.
When we talked about this, I laughed. This McAlpine doctor, pediatrician, attacked me. All of his followers attacked me for 3 days. Like, it has nothing to do with addiction. I was like, it does. It just does. And that's what we were seeing, is people's like saying, once I got my eating right, I'm not as stressed. I'm not as tense. I enjoy life. I don't have like Joan Iflin's talked about that a lot, where everyone around her wasn't being a jerk anymore when she was eating right. Right. It wasn't because they weren't being jerks anymore. It's because she was dealing better with them, and her temperament evened out. And so then you don't need that drink at the end of the day because you feel good. Your life is under control. It's really the symptom rather than the underlying root cause, right?
What I'd love to talk about here, because we're all clinicians here, and I know, Clarissa, that you employ models like cognitive behavioral therapy. I've seen sort of addiction, through alcohol, through drugs. I mean, we've seen it when you're a clinician, you see this, all throughout sort of hospitalizations are rife with this stuff, detox, et cetera. I have not seen cognitive behavioral therapy work incredibly well in other addictions, but in food addiction, it works so remarkably well. right? It works so remarkably. In fact, I'd say 90% of what we do here is making people aware of how their emotions, their logic, their outlook are somewhat manipulated by their relationship to food. So I want to hear, what your thoughts are on the modality of cognitive behavioral therapy here in food addiction. And then what do you do for those people that, because if you don't know what cognitive behavioral therapy is, it requires introspection and it requires, engaging party. And so, I've found some difficulty with that too. There's people who just don't respond. So we're in the process in our clinic of sort of figuring out, how do we figure out who's going to respond to cognitive behavioral therapy and who won't, right? So I'm just curious to hear, one brief line. If you're a listener and you're like, what's cognitive behavioral therapy? It's exploring sort of your emotions and logic related to behavior patterns you want to change. And it can be used in addiction, depression, anxiety, and a number of other modalities.
Yeah. And so I think what we found, or what at least I've found in private practice, and I think Molly can speak to this, is in early days, because the individuals we're working with are in some level inebriated or intoxicated by the foods they're eating, dialectical behavior therapy can be a better approach, meaning that this is really where we're giving people tools and they can take actions. So maybe we're talking about temperature. So is it that I'm having a craving? Because we know, like, when craving happens, it's happening up in amygdala. So they can't access their prefrontal cortex, which is like weigh the pros and cons. So we need to help them access that. So maybe it's temperature, going to get ice cubes, putting one in each hand, squeezing it until it melts, which now puts me back into my body, lets me access my prefrontal cortex. And that doesn't mean I'm fixed, but it means now I can, if I have an action plan, I can know what to do next. We have found the same as you, that later on, once we get out of that first 14 to 21 days, that now people are starting, that's when they're saying, oh, I can think clearly again. The fog has lifted. This is now a time where we can employ cognitive behavioral therapy and talk about, like, we'll get people to do thought records. And, that's why we employed these strategies in week 3 and week 4 of our program, and not in week 1 or week 2, because in those programs, like, you really just need what is going to help me in the moment and what is going to get me through this 20 minutes of a craving that is going to feel like 20 hours. Does that make sense?
Yeah, it makes total sense. And what we did here in our office was a little bit different. We offloaded the nutrition and upfront onto an education onto the app, because there's a lag between when they want help and when you can see them, right? So what we found is we've offloaded that to the 2 weeks before they could see you, or 3 weeks before they see you. They've already started that, and so we started essentially the elements of cognitive behavioral therapy on day 1, but we go back and forth as to whether that's ideal or not. So how have you found using cognitive behavioral therapy? How does it help your patients with addiction?
Yeah, I think that it is like a gold standard in the addiction world, absolutely, and it does have good effect with people, but not all people, like you were saying, Dr. Tro. And, so I think those people that it works for is who it works for. And those that it doesn't work for, I am actually somebody who, I like Jen's method. I like using solution-focused brief therapy. So I'm traditionally trained in cognitive behavioral therapy, motivational interviewing, all of that. And I've kind of left that behind. So Clarissa and Bethany really do that in Sweet Sobriety. And I'm more of the solution-focused brief therapy person. So I work with folks to really just start to get them to hear their own voice. Yeah, go ahead.
How do you guys split that apart? This is what I want to hear.
Yeah.
So that's a key point. And this is part of clinician. So here you have somebody, you're trying to help them. How do you go, well, you see Clarissa and then, or you know what, Clarissa's like, no, you, Molly, I think they're ready for you. How do you guys do that?
We actually let them decide. So Clarissa and I take turns. We kind of have a set schedule. Clarissa runs groups Mondays, Tuesdays, and every other Saturday. I run 2 groups on Thursdays, and then the other Saturday that Clarissa isn't running it. So people really decide who they want to see in that group, and then they can see us individually, right? Like that's up to them how they want to do that. But what we find, or what I have found, and what has been reported to me from some of the clients, is that they're intimidated by the solution-focused brief therapy techniques because they feel like they're on the hot seat, right? Because I'm showing up and I'm just asking them a bunch of questions, and they actually have to work a bit harder than with cognitive behavioral therapy or motivational interviewing, to be honest, right? Because I don't have an agenda. I'm just there to ask these questions, like, because my belief is everybody has a very good reason for doing the things that they're doing. So if you're showing up and you're telling me you're binging and purging, my belief is you have a very good reason for doing the thing that you're doing. And now I'm going to help you discover what is that reason, or what do you actually want? You don't actually want to be binging and purging. What would you rather be doing with that time? Well, I'd rather be spending that time with my children. I'd rather be spending that time with my husband, my wife, whomever it might be. And then we really start to break it down. Okay, if in this future place, that's what you're doing instead of binging and purging, how did you get there? How did you do that? Who would even notice that something was different about you? How would you know something was different about you in this future place? And so it's my job to be an expert in asking really good questions. It's their job to be an expert in their lives. So to be honest, there are the people who would benefit more from it, but they stick to the motivational interviewing and the cognitive behavior because it's familiar. Right? They get it. They know Clarissa's going to ask these very specific questions. They know that she's going to help them like put together the puzzle pieces, but then this is how you know it's not working for you. Then you don't go do the action after the group, because it's not really about what happens in group or those individual sessions. It's about what's happening in between. I find that with my clients who do come to me, there is actually more action in between. And that's just my personal experience, like all these years I've been in the field since 2005. So I've had thousands upon thousands of clients at this point, especially working in corrections because I worked in a facility. So I had many clients at one time. So that's something to think about. If you're a person who's going to treatment or working with somebody and you're not following through in between, what is that about? Do you need a different approach? Is it because it's too familiar to you? Whatever it might be. Now it's effective. I'm not bagging on CBT, DBT, motivational. I'm not bagging on any of those things. But if it's not for you, it's not for you. Just like the food plan, it's got to be for you.
What I've sort of come to the conclusion is, my goal is to get more and more effective over time and to assess that data. And we use health data to drive our performance, right? So, what better way? Like if a patient is truly over it, right, there or battling it and winning, right? This should come through on some health metrics, right? Not just sort of Yale food addiction scores or binge eating scores, which we also track, but some of their health metrics. And what we found is, I think, people of, slightly lower socioeconomic class or slightly, maybe just sort of blue collar, or they've been through the cognitive behavioral therapy, they're looking for more, they're looking for more. But what's your experience, Clarissa? What's your experience? How do you figure out, okay, when has this patient gotten enough and it's time to get a different approach, and how do you do that?
Yeah, and I certainly as well do a bit of a mix of solution focused and motivational interviewing, but I definitely, the reason why Molly and I created Sweet Sobriety was because there's no, legislation in or policies in food addiction treatment. And so we wanted something to be accessible. We wanted the most inclusive approach. And we charge $25 a month for 5 sessions a week. And that way anyone can enter in. And that's where we really encourage people to do what's necessary. I've also had, worked with clients for a year before they just start to pick up momentum. And I can't predict when a client's going to be ready. to make that change. Really, I use those stages of change. I'm seeing where they are. Is there improvement? Is there progress? Most of the time I have to highlight that progress for them because they're not seeing it, because they're in the trenches all day, every day. And so, it's definitely I think the accountability piece is important for them, but it's also important for us to be their cheerleader and not try to dictate results that they may just not be ready for. It won't matter what I do. Yeah, go ahead.
We've also worked together in running groups. Like when we were running the audit, we ran groups together. And so sometimes it would be clear. So whoever was kind of facilitating the group at the time, it might become clear to the other person that maybe whoever is being worked with right then on the individual level in front of the group, maybe wasn't quite getting what they needed from that particular technique, and the other clinician would jump in. I also think that because a lot of our clients who come to groups also see us individually, I might encourage one of my clients to go to Clarissa's group so that they get some of that CBT stuff, and vice versa. I know that Clarissa has definitely done that before. She's like, oh, I sent, a specific person to that group and I told them to raise their hand because I wanted them to get a taste of what you do, Molly, and so we see it, and I think it's more of like an intuitive thing. You've done this long enough, you're kind of starting to pick up on like, okay, they're just not grasping this for one reason or another. Let's try a different tactic and see if that kind of shakes things up.
You guys mentioned something that I think deserves to be highlighted, which is the fact that a lot of times people need a lot of encouragement, and but I'm also a big believer in empowerment, patient empowerment, right? And a lot of times things don't show up on a scale, right? But they'll show up on lab work. They'll show up on how people self-report hunger and their craving management, and they'll self-report. They'll show up on a blood sugar sort of meter, very quickly. And that's one of the reasons why I'm such an avid proponent of biofeedback, right? Is just being able to see, those changes, because it's tough. You said you're in the trenches. This is what you guys said, right? When they're in the trenches, so a lot of times we're just reminding them of the progress they're making, which I think is a testament to how disenfranchised and how vulnerable these people are, our patients are. So, do you guys?
I love that you said that, because we always say part of our, shtick is your data over the dogma, because there's so much dogma out there. And so whether that's saying, hey, go pick up a CGM for 2 weeks, get your blood tested, it would encourage, they always come to us for weight loss, but after working for us a while, they really see that recovery is not about the size of my body. And they release weight. It's just not like diet style weight. They maybe in the first week when they cut out some of those major carbohydrates, but then it's a slow and steady release of weight that they can maintain for their life if they just keep like eating in this loving way.
I think you're hit the nail on the head. Molly, what do you think?
Yeah, I agree. And that support piece, that empowerment piece, I think that's where we go back to, we're all about self-determination. We really build a culture within Sweet Sobriety that all of our group members have really taken on. It's been beautiful. There has not been any pushback, so knock on wood. But we build this culture where, group members meet other group members where they're at. We have people who are in the food. We have people who are 6 months, 8 months, 18 months out of the food, right? Like we have people that run this range, the spectrum, and no matter where they're at, when they show up, they're holding space for each other. There's no judgment. There's empathy, both tender and fierce, right? That they show up and they don't lifeboat anybody, but they also don't run anybody into the ground. And I think like that culture of just self-determination and harm reduction and all of that really shines through. And then they support each other, and they come to the free groups that we host. Then we have free support, peer support groups that we host. And then there's a WhatsApp group associated with that. And if you like, it's hard to keep up with, right? Like sometimes I just go check to see what's going on. I can't keep up with all of it, but just like somebody at 2 a.m. will be like, hey, is anybody up? And because we have people across the globe, right? Somebody's like, I've got you, and they're like supporting each other and checking in on each other. They're they're just fantastic. And I think that's it, right? Like that, ultimately, that's the key. In my 18 years of being in this field, you know, that quality support is like the number one factor in letting me know if somebody is going to be quote unquote successful or not, right? Like, I guess if we want to use that word successful, it all comes down to quality support. It doesn't have to be a lot of people, but it has to be good people. It has to be the right people.
100% agree. You know, that the community is so critical. You know, community is so critical. You need to, you know, and in fact, if you look at the obesity literature, I mean, this has been there. You know, if you look at the Framingham data set over 40 years, obesity spreads in social networks. And, you know, it's a testament to you're going to eat. I mean, we know this in the Alcohol Anonymous world, right? The Alcoholics Anonymous world. You will drink what your friends drink, you know, and just in that same way, you will eat and how your friends eat, and you're going to eat how your family eats. And so if you have a support system, it's so critical. 100% agree with you. And that touch points, like when you need it.
Yeah, and it's so true. Like for most of the clients I work with, they're going to eat this way, but their family's not going to change. And they feel already guilt and shame around, you know, is this addiction or I have to change, but they should still be able to have their stuff. And we just really need to present it like your family might not be on board, but I would say at least 60, if not more % of the time, I see people's families change. I've worked with clients and their therapist starts eating sugar-free because they see the change in these individuals and they want what that person has. Like they get to see this person that they love for so long, been suffering, get their life back, take their power back and start like living their life.
Yeah, 100%. We actually recruit family members too. I mean, we want you to bring everybody in, bring the au pair, bring the nanny, bring the whoever, you know, bring everybody. Because, you know, we want to change that social network that's around you, right? That social network is going to be there to support you. I think Brian may have left, but so it's just going to be me. You know, I know he had a patient care issue to handle. He told me beforehand. He's like, Tro. So, you know, I have. So, what is the future going to bring for Sweet Sobriety and for the Food Junkies podcast? And, you know, what do you guys? What are the next steps? Are you working on any other papers? I'd be interested to hear about that.
Yeah, well, we're working on, I think, our 12-month data paper right now, which will then be published. Both Molly and I are on the team that are working towards getting ultra-processed food addiction in the ICD. So we have been trying to, you know, work with individuals in the field, researchers to find out what is the term, right? Is it food addiction, carbohydrate, sugar addiction? And I think we're all pretty much, a lot of us have come to the idea that ultra processed food addiction, at least because it has a NOVA classification scale, is, you know, where we are leaning towards right now. So that's very exciting because, again, just I think having it validated in some form is going to help decrease some shame that a lot of individuals are feeling. And, you know, on the Food Junkies podcast, we love getting to meet awesome people like you and incredible guests. We just did a really cool like DNA testing for nutrition where it showed that like really both all Molly, me, and Vera require different macronutrient components to just show like there's not one way to recover, and that, you know, we need to start listening to our bodies. And we really want to get more into the somatic experience and always working on that self-compassion piece, because we know it's a nervous system regulator. And that for most of us, we've been beating ourselves up in our head our entire life for doing things wrong, when this is not a moral failure. We just didn't have the information. And now we just really need to talk to ourselves more kindly about, you know, the recovery journey we're on. Molly, did you have anything to add?
Yeah. Sweet Sobriety. We're in Sweet Sobriety. We have new workshops every month. So this month we had a clinical hypnotherapist doing a workshop. Next month we'll be running our foundations course, which will be free for anybody who's already purchased foundations, which is our course based off of that treatment audit that we did. I'm going to be running one on codependency. And then in the future, we're going to be doing like defense mechanisms, boundaries. Clarissa is going to be running a somatic experiencing 2-month workshop coming up, which is amazing. We're having our first live in-person meetup in Toronto in October. We have some guest speakers lined up, Sandra Elia and Vera Tarman and Dr. Evelyn and Sophie, some others. So and then we'll be at the next International Food Addiction Conference in the UK in May 2024. So there are some really exciting things coming up for us. And as Clarissa said, our work continues on the work that we're doing to get the ICD and or DSM on board, with lots of consensus meetings with folks, interviews, all of that. So if you have any questions, like you want to be a part of it, any of it, just let us know.
Yeah, I refuse. I'm going to adamantly refuse to call it ultra processed food addiction, because cheese and nuts and berries and simple whipped cream will make me eat until tomorrow. So
Vera would agree with you.
I agree in spirit to the term, but I think natural foods can be, and it's not as much of a problem, but certainly, a problem as well. Well, I'm really excited to see, all of this stuff, and thank you guys so much for coming on today. It's just been an absolute pleasure, and I know Brian had to step out, but he would say, thank you for doing what you do. People need the help. We need resources, and to have, a community to turn to like that has got to be such a help to people. And the fact that you guys have taken the extra step to publish the outcomes, I think that that's critical, and continue to do that. We need more of that in this field, and it can't just be some of us lonely, like pockets working alone. We have to start to work together.
Absolutely.
That's what we loved about the podcast too, is that we have met so many resources, and we've now connected all these individual silos that didn't really know each other. We're kind of like a networking matchmaking system as well now on the podcast. So so you can find us at www.sweetsobriety.ca. You can find us at thefoodjunkiespodcast.com. We're often in Vera's Facebook group, which is Sugar Free for Life. I'm Sweet Enough. Molly has her own practice, and I have mine, and mine is called Reinvent Your Bliss Point. So that's foodaddictionhelp.ca, and I'll let Molly tell you any of hers.
Yeah, it's probably easiest to find me at that sweetsobriety.ca, but I also have my own private practice, Unsugared You, and you can spell it with just the letter U or YOU. Both of them will direct you to my website. But you can get a hold of me. I'm the only Molly Painschab in the world. You Google me, it's only me. You can get a hold of me that way. I do Facebook Messenger, Instagram Messenger, email, WhatsApp, whatever it is that works best for you. You can get a hold of me, and I can get you connected with Clarissa, Vera, Bethany, whomever. Yeah.
Thank you guys so much for coming.
Well, thank you so much for
Thank
having
you.
us.
Yeah, it's been awesome, Dro.